Now let's examine some of the designs we actually use in the phase 3 or the comparative study. In phase 3, we've gotten to the point now where we know that the therapy can be given in some range, the patient is able to tolerate it, and that it's active. It does what we think it's supposed to do in terms of its immediate effect. We're going to compare the new therapy, the experimental group, with the control group. And I alluded earlier that we have 3 types of ways of establishing control: historical control, what we do now to what we used to do; concurrent control, comparing what we do here to what they do in another institution; or the randomized control. We tend to favor the randomized control trial as the gold standard because it eliminates many sources of bias. A nice discussion of this issue is presented by David Beyer and colleagues in 1976 when these issues were being debated, considered to be ethically the best method to determine which treatment is superior. So why does it have this wonderful property of minimizing bias? Well, the randomization process tends to produce comparable groups. In the randomized trial, the only place you can get differences would be by chance alone or if the therapy is effective. However, in the concurrent control group, you always have chance, but you can have selection bias. Who goes to which institution or to which physician may have a non-random process. So there's who goes is what we call a selection process or selection bias. The historical control study has chance always. It also can have selection bias, and now there's time. Things change with time. Patient practice changes, referral patterns change, ability to use a therapy improves perhaps. All these kinds of things will be changing over time, so we have even more biases to worry about. So randomization tends to balance these things and just get us down to chance as producing results unless the therapy is effective. A second point, which probably is less appreciated, except in the statistical communities, is that the randomization process actually produces valid statistical tests. Without randomization, we have to argue many assumptions about the distribution of patients, the distribution of the risk factors, etc., that we would prefer not to. But this is for me, esoteric point, which I won't dwell on any longer, but it's key to the statistician. Some of the commonly used phase 3 designs, I won't have time to go through each of them. I'll pick out a couple. We can talk about the parallel design, which I will cover, the withdrawal design, where you have patients on a therapy and you randomly ask some to withdraw from the therapy after a period of time and others continue. You can randomize groups or clusters, participants, perhaps at schools, factories, households. You can have a randomized consent design, where you first treat the patients in a treatment process, and then some of them get randomized unknown to them. If they get randomized into the experimental arm, they are asked to give consent. Those who are randomized into business as usual do not. This has some ethical issues that many people have discussed. There's a crossover design. Patients are on treatment A first and then treatment B, or on treatment B first and then treatment A. The factorial design, which I'll go over. There's a class of trials called large and simple. Very minimal amount of data collected, very large, tens of thousands of patients. An area which I'll also address, what is a equivalence or non-inferiority design, and then the sequential design. Let's take a look at the parallel design for a moment. This is the simplest of all designs, where you screen patients whether they're eligible for your trial. Once they are declared to be eligible and they give consent, they're randomized to treatment A or treatment B. Treatment B might be a control or a placebo. And you're trying to establish that the new treatment is better than the control. It's simple, it has broad use, and gives you valid comparisons, and most of the trials you'll read about in the literature probably are this parallel design. The disadvantage, of course, is that you can limit the number of questions you can ask. You have one comparison, treatment A versus treatment B, and you're limited to your questions to 1 or 2 primary and a limited number of secondary questions. But it's a very general design, well used. So a second design, which is slightly more complicated than the parallel design, is the factorial design. It's an idea of getting 2 studies for the price of 1. Here we have in this picture, the schema, 2 factors, factor 1 and factor 2. For example, in the Women's Health Initiative, we studied the use of hormone therapy, hormone replacement therapy, and the use of calcium supplementation, as well as a low-fat diet. So that had 3 factors. In this 2-factorial design, We are going to randomize treatment A and treatment B into one of 4 cells. Either you get both treatment A and treatment B, you get one or the other, treatment A or treatment B, but not both, or you get placebo. We're then going to conduct this study, and one of the analysis, the key analysis, will be to look at the margins, all the patients who got placebo versus all the patients who got treatment A, and we'll compare those. We will also compare all patients who got treatment B versus all patients who got placebo. And so we get to evaluate treatment A and treatment B versus comparable placebo. This trial makes an assumption that there's no interaction or synergy between the use of treatment A and treatment B, in which case we would not be able to make those comparisons quite so well. Factorial design have the advantages of 2 studies for the price of 1, which I've already described, but assumes that there are no interactions. That discovery may be important, but it also may compromise your ability to compare treatment A versus placebo or treatment B versus placebo. One of the problems is that we don't have a very sensitive way of testing for the interaction. So, in some sense, it's better that you have some outside information that says this is not a likely mechanism. Examples of the factorial design are the Physician's Health Study, which tested aspirin versus placebo and tested beta-carotene versus placebo, the aspirin component for coronary heart disease, the beta-carotene for lung cancer. Another trial is the Canadian Stroke Study. One of the challenges today in design and analysis and conduct of clinical trials is the so-called equivalence or non-inferiority trial. This is a trial that doesn't have a placebo control or a standard of care control, but it's comparing one active therapy with another active therapy. Why would you do that? Well, it may be that the new therapy that you're trying to evaluate is easier to administer, it's cheaper, has less side effects, and what you want to know is the new treatment, roughly speaking, as good as the current treatment? Now, it turns out that you can't statistically prove equivalence. You can only show that the difference that you observe is less than some specified margin that you write down ahead of time. And that's a challenge as to what that margin should be. It depends in part on the historical evidence of the sensitivity of the original, the control, to treatment. Small sample size leading to low power and subsequently a lack of significance does not imply equivalence. It just means you had no power or ability to find the difference. So in the design of non-inferiority trials, it's very important that you have a large study, large enough to detect the difference that you specify, and that the trial is conducted with the highest quality. This little diagram illustrates what the challenge is. Here we've looked at difference in event rates between the test drug and the standard drug, and we've defined some zone of non-inferiority. If this is event rates, then we've decided a difference between 0 and 2% would be okay in the assessment of the outcome, and if that was true, then we would be satisfied that even though the new therapy might have a slightly higher event rate within 2%, that is, other benefits, it's cheaper, easier, less toxic, would make it a good trade-off. So in this diagram, we've listed several scenarios. Study A, the little darkened box with A in the middle, is the estimate of the difference in our study, and the line represents the 95% confidence interval. So we're really very pleased about trial A because it not only demonstrated that it was not inferior by 2%, but in fact it was superior because the confidence interval excludes 0 in the right direction. The second trial, trial B, is also okay because even though it didn't demonstrate superiority, the upper end of that confidence interval is less than 2%, so it could be a little bit worse. It looks like it's better, but for sure it's not worse than 2%, which was our margin of indifference. Trial C, which results look like it's just slightly worse, still meets our non-inferiority criteria because the upper confidence interval is less than 2%. However, trial D is not met that criteria. In fact, it's worse than the new therapy, the standard therapy. And what you want to avoid in all this is scenario F. That trial, while it looks slightly better, the new treatment looks slightly better, it's so small that its confidence interval is so broad you can't say anything. So that trial, I would say, is probably unethical. It was never designed properly. It was a waste of time of both investigators and, most importantly, participants. So in the equivalence trial, we have several challenges doing a large, high-quality trial and specifying the margin of indifference that you'd be willing to make a trade-off from the new therapy to the old therapy if you could be sure that the true difference was less than that because there's some other redeeming features of the new therapy. These issues are being debated constantly these days as we evaluate new therapies which perhaps are less invasive, less expensive, less toxic, or some other feature. We talked about masked or blinded designs. There may be a trial which there is no blind possible, a surgical intervention, for example. Both the subject and the investigator knows which therapy was given, and we have the potential for both subject and investigator bias. The single-blind trial is meant that the subject is blinded, but the investigator knows which is the active therapy, which is the control therapy or the placebo therapy. The double-blind or double-masked study means that neither the subject nor the investigator knows which is the active or control arms, and this implies for sure a need for monitoring the results carefully because the investigator cannot monitor the adverse events. It doesn't know which group they took place in. Sometimes people talk about the triple blind, and that means that the people who are assigned to monitor the safety of the trial, all they know is it's an arm A or arm B. Most of us believe that the triple blind design is not a good idea, that some group needs to know who's on the active therapy and who's on the control therapy so that the true risk-benefit ratios can be assessed. But clearly our goal would be possible to have a double-blind study, but I said there are many situations where you can't blind the trial at all. In those cases, we really would like to have some third party make the evaluation that they're not the subjects, they're not the investigators, they're not involved in the daily routine of the trial, and therefore cannot bring any a priori bias. They don't even know the EKG they're reading or the X-ray they're reading from which arm it came. To illustrate how strong bias can be, let me show you just two really simple examples that I happen to experience in my own career. I got involved in a taste and smell study early in my career with an investigator who was really very creative and energetic and was studying smell and taste abnormalities. He observed that patients with taste and smell abnormalities had low serum zinc, so he set out to evaluate what would happen if he increased their serum zinc. He designed a single-blind study where the patients did not know whether they were getting zinc supplements or placebo, but he knew the way the trial was conducted. He knew which they were on. He devised a measurement which had 8 dimensions, sweet, sour, bitter, and so forth. And in his single-blind study, patients improved on all 8 of these dimensions. 8 out of 8 on the zinc improved, and none improved on placebo. These results were quite dramatic and, in fact, significant. However, because it was single-blind, his department chief said, let's repeat the study. After all, replication is one of the backbones of science, and asked him to do it this time in a double-blind setting. That is, neither he nor the patients would know which was zinc tablets or the placebo tablets. In this case, as you can see, 5 of the 8 dimensions improved on zinc, and 7 of the 8 improved on placebo. So the fact that the investigator, Dr. Hinken, understood and knew which treatment was active and which was control probably influenced his assessment of the patients and their ability to smell or taste. Well, this trial wasn't conducted to show this point, but it was a trial of a cold study that was conducted at the National Institute of Health among employees of the Institute, and it was a study to study placebo or ascorbic acid, and because the subjects worked at the NIH, they had the ability to unblind themselves if they so chose. When the trial was over, and they measured the duration of the cold, they asked the subjects, did you really keep the blind or did you break it? For those who kept the blind, the length of cold was 6.3 versus 6.5 days, no difference. But for those who couldn't resist and broke the blind, the patients who were on ascorbic acid had a much lower length of cold than those who were on the placebo arm. Well, this is not a perfect example, but it suggests to us that subjects themselves have bias as to how results should take place. So bias is very powerful, and we need to be always aware of how it can enter into our trial design and conduct. Randomization. I mentioned earlier that randomization really is our best way of eliminating bias. It tends to produce comparable groups between treatment A and treatment B, and it produces valid statistical tests. There's some very nice classical papers which describe these benefits in some detail. Now, there are several ways to achieve a randomization design. I will not go into all of them because of time, but there's a simple randomization, i.e. a coin flip. There is something we'll call a bias coin, which we'll talk about in a minute. There are permuted block designs, stratified randomization, a whole list of methods, algorithms to achieve a randomization process. Let's examine just a couple. If you were to flip a coin, simply, you know that you can get runs, several heads in a row or several tails in a row, and such an impact in a clinical trial would not be desirable. You would like to have the same number of patients on treatment and the same number of patients on control. While it's valid statistically, it is usually awkward and makes investigators uncomfortable when they have such a result. So, a permuted block design has been decided where you make sure after every certain number of patients that the number of patients on treatment A and treatment B is the same. We call it a block design because we choose a sort of block of patients in which we make sure that all the number of patients on A and B are equal. A little example is probably the best way to describe this. Suppose we choose a block of size 4. We have two treatments, A and B. There's 6 possible ways we can rearrange the assignment of A and B within 4 patients. Let's write down all possibilities. I've done that in the brackets below. So now we have 6 possibilities, AA, BB, AB, AB, BA, AB, and so forth. So imagine we write those 6 designs on 6 pieces of paper and put them into a hat, and we stir them around and we pull out one piece of paper. The first piece of paper we pull out has the list A, B, A, B. So the first 4 patients will be assigned in that order. Patient 1 will be A, assigned to treatment A. Patient 2 assigned to treatment B. Patient 3 assigned to treatment A. And patient 4 assigned to treatment B. Well, now that we've assigned the first 4 patients, you'll notice that there's 2 A's and 2 B's. Everything's even. Put that piece of paper back in the hat, stir it around again, and the next piece of paper we pull out as BA, BA. So patient 5 gets assigned to treatment B, patient 6 treatment A, and so forth. We keep doing that process, and we can assure ourselves that after every multiple of 4 patients, we will have the same number of patients on A and the same number of patients on B. One of the concerns about this design is if you happen to know the block size, then you will know that after every 4 patients, things will be even. So if you've randomized 3 patients, you know what the 4th patient might be. So if it was a blinded trial, you might unlikely be able to figure that out. But if it was a single blind or an unblinded trial, that'd be a possibility. Well, one solution to that is just randomly pick the block size, and then you can never keep score whether you're blinded or not. Another desire is to have patients balanced within certain prognostic or risk factors or covariates. For large studies, theory says and practice demonstrates that randomization will tend to give balance not only overall, but it'll give pretty good balance within the risk factors or subgroups you're interested in. For smaller studies, that might not always be the case, and so if you're concerned about a particular subgroup, you would like to make sure there's a little more balance. So what you do in that case is you divide your trial use your risk factors and divide the trial into categories, or what we call strata. And then when a patient comes along, we'll randomize them within each stratum. If you're going to do stratified randomization, though, it's important that you use one of these restricted randomization processes, such as the permuted block design. Otherwise, in fact, you will not achieve balance. Let me illustrate a simple example of what I mean by stratified randomization. Here we want to randomize by gender and by risk. 2 genders, 2 risk groups. So we have male, female. For males, we have high and low risk. For females, we have high and low risk. So we wind up with 4 strata. 2 factors, 2 levels within each factor, so we have 4 strata. So now along comes a patient who is male at high risk. Being stratum 1, we'd use, for example, the permuted block randomization design and randomize patients in that strata. Next patient might be female at low risk, and so we'd randomize by a different randomization schedule to patients in strata 4. This process then will tend to produce comparable results within each of those 4 strata within treatment A and treatment B. Many times the statistical input is delayed until they get around to thinking about sample size. I hope I can point out to you that sample size is not the first issue that has statistical implications, but in fact it's very key. Trials must have sufficient power to detect the clinical difference of interest. There was a time when many trials were published that were not large enough. In fact, in 1978, a survey was done of 71 trials that had a negative result. That is, they did not find statistical significance. P was not less than 0.05. But a closer examination of those studies illustrated that 50 out of those 71 were so small they could have missed a 50% benefit. That would be a tremendous effect, and yet they couldn't have found it. So we need to have trials that are well designed and adequately sized to detect what you're looking for. How do we do that? Well, an example might be illustrative and instructive. Suppose you have a new treatment labeled capital T with a control study arm labeled C. Previous results suggest that failure rate in the control group rate is about 40%. That is, the failure rate P sub C is about 40%. And we believe our new therapy can improve upon that, to improve that failure rate and reduce it by 25% from a 40% rate of failure to a 30% rate of failure, i.e. a reduction of 25%. The question is, well, how many subjects do I need in my study, in each arm? Well, I need to remind you of a few statistical principles or structure. We always talk about the null hypothesis. It's true of science, not just of statistics, that there's no difference in the response between the treatment arm and the control arm. That's the null hypothesis, no difference. But we wouldn't be doing this experiment if we didn't believe there was some alternative to that null. We like to disprove the null and say we believe that the alternative is true. And we believe the difference experimental and the control therapy is of some size. We call this delta, capital delta. So we are going to design this study hoping to disprove the null hypothesis and hope to detect a difference of size delta or bigger. Now there's two ways we can go wrong. First of all, we can claim there's a difference when there isn't, just by chance. We call that a type 1 error. The significance level specified as alpha. What we mean by that is the probability of rejecting the null hypothesis and saying it's not true, when in fact it is true. So we obviously would like to minimize that error. That's claiming therapies are effective when they're not. The second is a type 2 error, which means we don't find it when we should, when it's actually there. There's a difference, we just don't see it. 1 minus that probability is what we call power. Power is the probability of rejecting the hypothesis given that it's not true. So we want all of our trials to be, quote, powerful, large enough to find differences that are really there. How do we use these concepts for sample size? We typically want to set our failure rates, type 1 error, or a false positive claim, to be small. Convention, no theory, but convention says we want to be less than 5%, sometimes 2.5%, or even 1%. We don't want to claim therapies are beneficial when they're not. We also would like to have a pretty good chance of finding what we're looking for. So we define power to be at least 80%, better yet, 90%. That is, we have a 90% chance of finding the difference we're actually looking for. And we define delta as the smallest difference that we hope to detect. In my little example, I've said I think we can reduce the failure rate from 40% to 30%. So delta is 0.10, or equivalently a 25% reduction. We will not have the time for sure today to talk about this formula as in the center of this slide. But I want to just point out some features. This formula will determine how many patients we need in each arm, depending on these other factors. You'll notice the term Z sub alpha. Another term is Z sub beta. There's P bar, and there's delta squared. Well, Z alpha is a constant value that's associated with a particular alpha significance level. For example, if we set the significance level at 0.05, then that Z alpha in a two-sided test would have a value of 1.96, something you may be familiar with, two standard errors. The Z beta is the constant associated with a certain amount of power. For example, if we wanted to have 90% power, then Z beta would be a value of 1.28. And there's tables of these values that you can look up in standard statistical texts. Now there's two other factors that we need to examine. There's P bar, which is the event rate on the average that we expect. And then there's the delta. If delta, the difference we're looking for, gets really small, you notice it's in the denominator and it's squared, the sample size can go up quite rapidly. Likewise, not shown here, if you change the significance level from 0.05 to say 0.01, the constant associated with that change goes up as well. And likewise with power. So the lower the type 1 error or false positive rate, the larger the Z alpha, the greater the power, the larger the Z alpha. So you want very significant, very powerful trials, sample size goes up. you want to detect smaller differences. Sample size goes up. So these are factors which are playing off of each other, and we need to try to figure out for our trial what's the best balance in these factors. I've shown a little table here to illustrate how this might work. The first column is the failure rate in the control. I've postulated in the second column potential alternatives. Then I've given the sample size for a alpha of 0.05 one-sided, skip that for today, and a alpha of 0.05 two-sided. So let's examine the case that we started out with. An event rate of 40%, that's in the shaded area, reduce it to 30%. In the right two columns, I've given you two sample sizes. One for a power of 90%, which says we need a total sample size of 960 patients. If we reduce the power from 90% to 80%, we can get by with 720 patients. Well, why wouldn't you go to 720 patients? Well, we could, but we're now taking a larger chance of missing something. We're taking a 20% chance of missing what we're looking for. If we were to reduce our criteria for a false positive, you notice we can, and we move into the one-sided arena, we can reduce our sample sizes to 780 and 560. However, for a lot of reasons, we don't recommend a one-sided test, even though it's attractive to reduce your sample size. It has many other problems. But you can see as the event rate changes in the control arm, the sample size changes. As you change the significance level, the sample size changes. And as you change the power, the sample size changes. So as we look at design of trials, we need to find out what's our best estimate of the control group failure rate, what delta we really are serious about finding, what kind of risk we're willing to take in terms of false positives and false negatives, and use those factors to come up with a sample size that's appropriate for our trial. I have another graph here, which is perhaps a little more complicated, but on the y-axis I have the total sample size, 2n. On the x-axis, the horizontal axis, I have the percent reduction in the event rate, and I have several curves on this graph, each representing a different rate in the control arm. So we talked about a 25% reduction in the control rate, and we were looking at a 40% control arm failure rate. So you can see, pick out the PC equal 0.4 curve, a 25% reduction rate, and if you follow up and extrapolate back to the y-axis, you can see something less than 1,000 patients. But suppose we were wrong in our estimates of the control group rate. That is, the screening effect was powerful. We didn't get a failure rate of 40%. We only got a failure rate of 20% in that control arm. If we were still insisting on detecting a 25% reduction, the proper size of that trial would be 2,500 patients if you follow the dashed line up and over to your left, not 1,000 patients. So if we design the trial expecting a 40% rate, get a 20% rate, we will have a problem that we have much, much less power to detect that difference of 25% reduction than we had hoped for. So these are all factors that we have to really examine carefully in the design of our trial because they have serious implications for our ability to be successful. There's another little problem we need to take into consideration when designing trials and the sample size. We know that patients may not comply perfectly with the therapy or the regimens that we are studying. They have the right to refuse. They have the right to take as much of the tablets as we assign them. We would encourage them to be fully compliant, but they may not. So how do we deal with that? Well, some, as I'll show later, might decide to throw out the non-compliant patients. I'll argue later that that's a bad idea. The alternative is to try to adjust for it in the design and build up a study that can tolerate such non-compliance. I've got a little schema here which goes from 0 to 1, and I've plotted hypothetically an event rate P sub t, hypothetical, and I assumed control group rate P sub c. Now suppose that the control patients tend to start taking some of the therapy. It's possible if you were studying aspirin or hormone replacement therapy, patients may say, well, I don't know which arm I'm in, but I'm going to start taking some of this anyway. So that the failure rate might not be as high as you think. It'd be a little bit less. On the other hand, the treatment arm may say, some of these side effects I don't like, so I think I'm not going to take that therapy anymore, that medicine. Instead of having an optimum event rate of P sub t, you'll get an event rate a little higher than that, P sub t star. So because of this non-compliance, you're really not looking at a difference of PT to PC. You're looking at a difference of PT star to PC star. a smaller difference. Just in a sort of a rough approximation, what's the impact of that non-compliance? Well, I won't, again, take the time to derive the formula, but in the middle here of this slide, it says that the n star, the adjusted sample size, is a function of the ideal sample size by these two non-compliant rates, R sub 0 and R sub I, for the control arm and the intervention arm. If, for example, a 10% non-compliance in the control arm, R sub 0, and a 10% non-compliance in the treatment arm, R sub 1, then the impact of that would be that you would have to increase your sample size by 56% to compensate for this dilution. 10% non-compliance in either arm would be pretty good, all things considered in trials. You may be unlucky that the non-compliance rate in the control arm and or the treatment arm is as high as 25%. Not common, but nevertheless observed. The impact is that to compensate for that non-compliance, you'd have to have a trial 4 times larger than what would be ideal if there was perfect compliance. Well, you can see the impact is rather dramatic. So one really needs to take this into consideration in your design and understand from previous trials and your knowledge of the situation to make an estimate of what the non-compliance will be. But to ignore this is going to be troublesome, and you can't toss out the patients who are non-compliant. I'll illustrate that a little bit later. One challenge, another challenge, I guess, in trials is the issue of data collection. There's a very nice discussion by Kurt Meinert in his textbook, which he goes over the issues, what data to collect. In general, as I say at the bottom, we tend to collect too much data. We get carried away. But there's certain data that we must focus on. We need to understand the recruitment process and who is eligible and who gets in. Did they meet the criteria? We want to assess something about their risk factors, so we might want to measure a lot of important baseline covariates, who was studied and was treatment balanced, to get some assessment as a comparable trial and get the patients we want. We want to get some measurement of compliance. How much of the medication did they take? Did they use the device as proposed? We've talked about adverse events or toxicity. This is always a problem as to how much you measure, but we need to be careful and get important toxicity measurements recorded. Of course, we want primary and secondary outcomes, and maybe some limited ancillary information. We want to get it at least in 2 points in time, at the beginning, at or before randomization, and sometime later. So we need to pay attention to data collection. If it's done haphazardly, you will have a challenge in trying to assess your study. So we have to plan ahead and plan carefully. But I said the tendency is to collect far too much data. It's expensive to do so. It costs money to enter it, to clean it, to analyze it, and in fact, often much of it's not used. So this is an area, again, where even in today's clinical trial world, we have many things to make improvements on. Well, again, thank you for listening. We've covered so far some of the fundamentals of design and conduct. In part 3, we are going to consider some aspects of monitoring trials for benefits and risks, as well as some key principles in the analysis of the data that results from this trial.